Up next, Richard Conti is joined by Dr. Robert Guyton, Professor of Surgery and Chief of the Division of Cardiothoracic Surgery at the Emory University School of Medicine in Atlanta, Georgia. They cover 2014 AHA-ACC Valvular Heart Disease Guidelines, the impact on clinical practice.
Bob, why don't you start out by sort of giving us an example, a couple of patient examples.
Right. Now, as we operate on older and older people, particularly when we do transcatheter valve procedures, two patients come to my mind. One patient is a patient that we put a transcatheter valve in, and a year later, they walked into the restaurant I was in Atlanta, and they said, Dr. Guyton, this is the best thing that ever happened to us. Then another patient, a letter I got from the daughter of the patient, that said, my mother went through this transcatheter valve. She was in the hospital for 4 weeks, and she never got better. She never improved. Her symptoms never improved. And if we had known this was going to happen, we never would have gone through with this. So I think that one of the things in the guidelines that I think is critical is a new risk assessment and a new understanding of who should be operated on and who shouldn't that goes beyond just survival or death, because the STS predicted risk of mortality that we've used for years talks about survival or death, and we need to talk about a lot more than that.
Does the STS include valve surgery? It's not just coronary heart disease.
Absolutely. There is a risk assessment now for aortic valve replacement with coronary bypass, and mitral valve repair and mitral valve replacement. So all of those are in the STS, but there are things that aren't in the STS that are in the new guideline. And we need to talk, when we talk to the patient, about 3 outcomes, not 2 outcomes. The STS predicted risk of mortality is just that, predicted risk of mortality. Now, it also predicts stroke. So that's one outcome. The patient is operated on, they die, or they have a stroke. So we all view that as a very bad outcome. That's the bad outcome group. Then there's the good outcome, which is survival with benefit, that the patient is better or they live longer.
Like your first patient.
Like the first patient.
Right.
And that is the very positive outcome. But then there's also a group of patients, particularly as we're operating on the older patients, of survival without benefit. And I think we've all seen that in our practices. We operate on somebody, the operation takes a lot out of them, particularly somebody who's 85, 88, 89 years old, and sometimes they never regain their vitality. And when we look at those patients, we say, I wish we could have figured out how we could know not to operate on that particular patient, how we can sort that out.
How about their brain function, cognitive function?
I think that's a thing that is also potentially decreased, partly by the heart-lung machine, but also we know that as you age, your neuron reserve is diminished, and anytime you go through a period of any kind of stress, there's a decrement in your cerebral function.
Sure.
So I think that it's not just the heart-lung machine, it's going through a period of stress. So there is a potential decrement in cerebral function.
Okay, so what else?
Well, I think let's talk a little bit about the new risk assessment in the guideline, because I think in the guidelines there are 4 categories of risk assessment. First is the STS predicted risk of mortality. In general, if your predicted risk of mortality is 0 to 4%, you're in the low-risk group. In the 4 to 8% area, you're in the intermediate group, and above 8% in the high-risk group. But also, we have frailty. The new guidelines-directed frailty assessment talks about the 6 activities of daily living and independence and ambulation. And if you have one of those frailty indices that's positive, that moves you over into the intermediate risk category. If there are 2 things that are involved, that you can't walk and can't take care of your daily bathing, for example, then that moves you over into the high-risk category. Then the next thing is organ system dysfunction, because we know that if we operate on the heart and there are other organ systems that are not working, the kidneys, for example, or the GI tract with Crohn's disease or ulcerative colitis, then we know that those patients are not going to do as well, and there's specific data on this. If one or other organ system is involved that's not going to get better with surgery, then that moves that patient to the intermediate risk. If 2 organ systems are involved, then that moves the patient to the high-risk category. If 3 organ systems are involved, and this could include left ventricular dysfunction that's not going to get better with valve replacement, then that moves that patient over to the prohibitive risk. And that's the kind of 3 strikes and you're out rule. If you've got 3 organ systems that aren't working, say your lungs and kidneys aren't working, but your heart's going to be all right, maybe you could be operated on in the high-risk group. But if your heart's not going to be robust after surgery and your kidneys aren't working and your lungs aren't working, then we should leave those patients alone. And it's very interesting that particularly with transcatheter valve replacement, we sometimes operate on those people, replace their valves, and they don't get better. Then there's a final category, which is the special surgical impediments to valve operation, such as a calcified ascending aorta, a hostile chest. We had a patient recently at Emory that had 7 previous sternotomies. It was a challenge to put a transcatheter valve in, but we ended up being able to put a transcarotid valve in this 20-odd-year-old young man who'd had 7 previous operations. So there are alternatives, but there are a lot of surgical challenges, which we can overcome these days, but we have to be aware of the risk, and it has to be a patient-centered discussion where we discuss it with the patient. And particularly these days with transcatheter valves, you're discussing it with the patient, but also the children of the patient, because when you discuss it with an 80-year-old person, the children usually are 60, 65 years old themselves, and they're very much involved in the discussion.
You know, I've found that putting patients into hospice, for example, if you have cancer, it's easy. If you have cardiovascular disease, it is not easy. And your new system identifies people that probably should be in hospice, make them comfortable, feel good. I like that. I mean, it's not easy to do with cardiovascular because the children all think we can keep people alive forever. It doesn't work that way.
Right, they're thinking the heart is just a pump and we should be able to fix that pump.
That's right.
Pumps have valves, we should be able to fix those valves. But I think the reality is that when there are other organ systems involved or when the patient is frail or deconditioned, we have to talk about survival but not getting better. That is survival of a deconditioned patient, but the patient doesn't regain their vitality. And that in some ways is a worse outcome than death.
I agree with it. You know, I have a simple formula for identifying people who are at high risk. If you have a chronologic age, let's say, of 80 or 85, if you look young, feel young, and act young, you probably are young. If you don't, you're not so young, and you may be a little bit delicate to undergo anything.
Right. There's another criteria that surgeons often use, and that is if the patient is still driving and independent in society, which often means still able to drive, able to get themselves around, then that usually is somebody that the operation is going to be successful. If the patient has stopped driving, that may be a physical or cerebral issue that you need to think twice about.
I guess what you're telling me, and I think what you're telling me, is that surgeons need to talk to the patient about these things and the patient's family so that everybody is on board and knows what's going on. And that doesn't always happen, believe me.
It does not, and you have to go beyond survival and stroke, which are the 2 things we usually talk about, but we need to talk about, are they going to get better? Right. What are the expectations for getting better? And I think the new risk algorithms in the valve guidelines give us a framework in which we can have that discussion.
Are these published now?
Yes, they are published in the 2014 guidelines that came out last year.
For valvular heart disease.
For valvular heart disease.
Well, I think we'll end on that note. Bob, thank you very much. This is a very important discussion.
Thank you very much. I appreciate it.